concern from your compromised patients. That's
We have not established those standards yet because they will come in the testing lab rules, which we have an extra 120 days under House Bill 523 to draft, share with the public, and collect feedback on. And so it's a very important thing to bring up, and certainly something that we'll be paying attention to.
Anything else in the committee? Okay, we'll move on to Mary.
So the State Board of Pharmacy's role is multi-tiered as well, much like the Department of Commerce. And our responsibility under House Bill 523 is we're responsible for rules relating to the registration of patients and caregivers, for retail dispensaries, and form and method administration for medical marijuana. Accompanying those rules, we're also authorized to enforce rules related to patients and caregivers and dispensaries, to use the Ohio Automated RX reporting system, and you heard a little bit about that this morning when our Executive Director, Steve Sherholt, spoke. That's what pharmacies use to track prescription monitoring. So we're going to use that. We're authorized to use that for the collection of information related to the dispensing of medical marijuana and for registered patients. And then we also are authorized to disseminate registered patient information to retail dispensaries so that they can check the registration before they sell. With respect to patients and caregivers, we're responsible for establishing a process for patient and caregiver registration within 1 year of the effective date of House Bill 523, and that's September 8th of 2017. We're also required to determine standards for when a registration can be revoked or suspended, and the conditions under which a registration can be reinstated. We need to establish a program to assist veterans and the indigent in acquiring medical marijuana, and attempt in good faith to enter into reciprocity agreements with other states. With respect to dispensaries, we also have a 1 year timeline for this. So not later than September 8th of 2017, we must adopt rules establishing standards relating to the procedures and fees for licenses issued to dispensaries, owners, operators, and employees. We have to establish the number of retail dispensaries, license renewal schedules, the conditions under which a license may be revoked, as well as when a license can be reinstated, determine training requirements for employees, and then we also need to determine when a pre-existing dispensary that now violates the 500-foot rule, and there's a provision within 523 that prohibits these entities from being built within 500 feet of a school, a church, a preschool, a playground, things of that sort. And when they may remain, when they have to relocate, or when they must have their license revoked. Now, with respect to forms of medical marijuana and the methods of administration, House Bill 523 approved 5 forms of medical marijuana that can be administered. Oils, tinctures, plant material, edibles, and patches are all authorized under House Bill 523. And then it also prohibits forms and methods of administration that are attractive to children, and forms that require smoking or combustion. It does expressly authorize vaping. Oh, thank you. Our rules, to build on that, the marijuana content form and administration, require us to specify by form and THC content a maximum 90-day supply of medical marijuana. We have to specify the paraphernalia that may be used by a registered patient of medical marijuana, specify forms that are attractive to children, establish a process for review and evaluation of petitions for new forms or methods of administration of medical marijuana. And then we also need to establish a toll-free hotline that's going to be used to respond to inquiries from patients, caregivers, and health professionals regarding adverse reactions to medical marijuana, and to provide information about available services and assistance.
Okay, let's pause there. Committee, any questions from a Board of Pharmacy perspective? Yes.
Thank you. Aaron, you mentioned reciprocity with other states. What types of reciprocity do you envision?
We have to look at the other states that have programs similar to ours and establish agreements with those other states that they would recognize our patients there and that we would recognize their patients here in Ohio.
Hi, Erin. I just wanted to clarify the last slide that you had up there, especially for things like the 90-day supply and establishing funds that are particularly I guess, ideal for children and avoiding those. Can you tell me if there will be any quality improvement process so that we can reevaluate those things? So if we define a quantity for a 90-day supply, will we be able to revise that at any point?
Yeah, so one of the things that we're really concerned about program-wide is building in flexibility. So we want to make sure that we can be responsive to the program as it grows and as it evolves. So we can make it right for Ohio.
Thanks. I got two quick questions. Can you define for me what your definition from the Board of Pharmacy's standpoint is of a retail dispensary? Like how you see that operating, what it looks like? Is it like a CVS that also has like a medical marijuana line? Is it like a freestanding like something?
These are going to have to be independent of retail pharmacies today because DEA licenses would come into play with an existing pharmacy.
Sure.
So there would be that concern for a CVS, for instance. These probably do not exist today. They do not exist today.
Okay. And so, and pardon my ignorance about this, but I feel like I've been reading reports in the news and the media about various communities and cities saying, look, we don't want this in our city or in our township, and perhaps some city councils may be passing resolutions to say that they don't want this in their township. How do you see that affecting the rollout of this project?
This is true. So we have been monitoring when that's happening, where it's happening. A lot of what we're seeing in Ohio so far, and I should mention too, that's not unlike other states. Even Colorado has areas that have prohibited medical marijuana entities from being established within their jurisdiction. What we're seeing a lot in Ohio right now are temporary moratoriums on the existence or establishment of a medical marijuana entity. And people are waiting to find out what the rules are going to look like before they make final decisions in most cases.
Aaron, excuse my ignorance on this question. For the dispensaries, is there going to be a requirement that there has to be a pharmacist on site in those dispensaries?
There is no requirement written into House Bill 523 that a pharmacist be on staff or on site at a medical marijuana dispensary.
Are cultivators also allowed to own dispensaries?
The bill itself is silent on vertical integration.
However, physicians, for example, that prescribe cannot, correct?
Physicians who recommend medical marijuana are prohibited from owning a dispensary, yes.
So Aaron, are you prepared to address the question of vertical integration at that time? Is that putting the cart before the horse, or do you discuss that? Maybe this is a more appropriate question for Missy.
I mean, there's, thanks Ted, there's nothing in the bill prohibiting it, so how that rolls out is something we're trying to be mindful of, but how that rolls out specifically, we're still contemplating as we continue to write rules.
Other questions or comments for anyone that's presented so far? Okay, Kimberly, Chief Legal Counsel for the State Medical Board, and then we'll talk about the physician component of this House bill.
Thank you. I think first I'd like to start with a little bit of a clarification. So we've been talking about recommending versus prescribing. So for the physicians who are going to be involved with this program, they cannot prescribe. The federal government prohibits that because it is a Schedule I controlled substance. What the physicians can do is recommend medical marijuana, and so that's the terminology that we'll be using, recommending versus prescribing. So the patients must have a recommendation from a certified physician, and interested physicians must apply for a certificate to recommend, which we're abbreviating as CTR, from the State Medical Board. The process to obtain that certificate to recommend will be established in our rules, which must be adopted by September 8th of 2017. And then to talk a little bit, we have rules in several areas that we will be promulgating through House Bill 523. The first would be the procedures that the physician must follow when applying for a certificate to recommend, conditions that must be met for a physician to be eligible for a certificate to recommend, information, more detail about the renewal process. We are envisioning that this is a license that attaches to the current MD or DO license. The reasons that a certificate to recommend could be suspended or revoked, and the standards under which that suspension might be lifted, which will fall into the board's existing disciplinary processes under the terms of House Bill 523. And then we also have to establish the minimal standards of medical care when recommending treatment with medical marijuana, which will be our largest lift. In addition, we will be working on rules around the annual reporting process, which was mentioned earlier. Physicians who recommend medical marijuana will be required to provide a non-patient identified annual report back to the medical board regarding the effectiveness of the use of medical marijuana for their patients. So we will be working on rules around that, and we will also be working on rules around the petition process to add conditions. And so currently we have 21 conditions that are pretty wide-ranging for patients to be eligible. So patients with diagnoses of these 21 conditions could be eligible for a recommendation for medical marijuana. And then there is a provision in the statute that allows any person to make a petition to the medical board to add conditions. And you know, there are several factors that must be met for that petition in the statute, and we will also be working on rules around that as well. And then lastly, the temporary language in House Bill 523 included language related to an affirmative defense for persons charged with marijuana-related crimes. And it potentially provides a defense for medicinal use when accompanied with a physician recommendation. The medical board has issued a position statement on the affirmative defense clause, and it is available on the Medical Marijuana Control Program website. And we would encourage you to look at that.
Okay, thanks, Kimberly. Questions for Kimberly from the medical board perspective?
Thank you. Hi, Kim. You know, I know that at the medical board we have a lot of requirements when you, for example, write an opioid as far as documentation. And I think Dr. Mitchell brought up a really good point about documentation requirements for the medical marijuana recommendation. I know that we have to establish minimal standards and there could be an annual report, but do you perceive this medical marijuana recommendation rollout to be similar to that of like an opioid, where, for example, in opioids we have to assess the 4 A's: activity, aberrant behavior, analgesia, adverse events, that kind of stuff. How do you see that playing out?
You know, we are working on our rules, but we are envisioning that the minimal standards rule will have documentation requirements, and the statute does require checking ORs So that will be something that will be included, and we are envisioning that there will be certain standards that need to be met. I think most importantly is credible evidence that the patient has the diagnosis will be a large part of that minimal standards rule, and then documenting how that was determined, since having the diagnosis makes the patient eligible.
Just one follow-up to that. Will it be necessary to have documentation that the patient is benefiting from the treatment at the same time? There's follow-up there too. So you mentioned that the law allows you to have patient to suggest that a new disease be placed on the list. Will there be feedback so the list is fine-tuned for the benefit of other states who are doing this to say, look, if this is where it works, this is where it doesn't work? Is that also something that your board will handle?
I think that combines several of the provisions in the law. The annual report is going to give us the most direct information about how that is working for patients, and we're still envisioning how that's going to work, and are certainly open to feedback on that. Then with respect to the petition,